Hello everyone, today we are going to study about the arm and the elbow. In the previous video we have completed the fracture and the dislocation of the shoulder and the clavicle. Let's go with the arm. First we have to know about the proximal humerus fracture. So this is the most common in the osteoporotic women or the menopause women, because of the in the menopause, if there is less estrogen, then there will be the less osteoprogenitor, and which will bind to the rank ligand, so that it cannot bind to the rank and activate the osteoclastic activity. So in the menopause women, there is less estrogen, so less osteoprotein and more osteoclastic activity will be there. And the cause is like must like fall on the outstage hand, and the most common fracture is in the surgical neck of the humerus. So most common nerve which is affected is axillary nerve. So for the management, like if it is undisplaced fracture, then we have to do the conservative management, and we can use the arm sling or pouch. And for the unstable fracture, then we have to do the surgery. We have to we have to do the open reduction with internal fixation. So there is one classification called Neer classification. It gives the 4 types, like in first undisplaced, and in two parts of the fracture, and in third 3 parts, and fourth there will be the ost prognosis. So for this is the thing which you need in the proximal humerus fracture. So another is shaft of the humerus fracture. In this there will be the radial nerve injury, most common nerve injury in this. First, in the proximal humerus, there will be the axillary nerve injury, but in the shaft, radial nerve injury. And then in the lower third of the shaft, then the middle third, there is more chance of the radial nerve injury, because radial nerve is fixed to the septum of the at the lower third. And then that is called as whole stents Lewis sign. Also in that there will be the wrist drop, and we can use the cock cup splint, which is used to immobilize the hand. So most common site of the humerus fracture in the shaft is junction of the upper 2/3 and the 1/3, and it is also called as Holstein and Lewis fractures. So for the management, if there is the fracture with no radial nerve palsy, then we can do the conservative management. We can use hanging cast and use slab. But if there is no radial nerve palsy, like we can do the neuropraxia, like recovers if it recovers within the 3 months. If not recovering, then we have to do the nerve conduction test. If it is recovering, we have to wait and watch, and if it is not recovering, we can do the surgical exploration. So if there is open fracture, we have to do the open reduction and the internal fixation with the exploration of the nerve. So we have to know the 3 bony relationship, which can make the triangle when it is 90-degree flexed in the elbow. So like from the humerus, there will be the middle epicondyle and the lateral epicondyle, and the lower will be ulna and the tip of the ulna. So these 3 bony prominence makes one relationship, like triangle like thing figure. If that the figure is displaced in the fracture displaced, then we can suspect some fractures. Like this triangle is seen in the 90-degree flexed makes triangle, and if on the extended elbow, then these 3 lines will be in the same line. So in the supracondylar humerus fracture, there is no disruption of the these 3 bony point. But in the like olecranon fracture, middle condylar fracture, lateral condylar fracture, intercondylar fracture, and the elbow dislocation, there is like these 3 bony relationship will be disturbed. So these are the things which you need to know. So in next video we will talk about the supracondylar humerus fracture, which is very important in the exam also. So thank you.